It's getting consistent water. I jumped it down. It's 78 degrees. All right, we are now live and Senate Health and Welfare is back. And we are continuing our work for today, looking at getting some testimony on H 266, the 340B prescription drug pricing bill. And we're going to introduce ourselves first, Dawn, and then we'll have you introduce yourself for the record and give your testimony. So we're going to start over here with Senator Hart.
Senator Larry Hart, Orange County, represent you guys.
Sam Douglas for Phoenix County.
Jenny Lyons, Chittenden Southeast.
Shipment Central. Comes Washington District, which includes Braintree and Florida.
So you got us. Here we are. Oh,
Well, it's very nice meeting you. Thank you for having me. My name is Dawn Potter. I'm here from Gifford Healthcare and Gifford Medical Center. Gifford Healthcare is an SQHC. Gifford Medical Center is in CAH or in a hospital. And
critical access hub.
yes, Critical Access Hospital. And I am the 340B coordinator for growth.
Oh,
So I live and breathe 340B every single day. I'm not gonna go over all of the 340B stuff, because I'm sure you've heard about it. And we are all for the transparency. We know that numbers need to be found that can help, ascertain why costs are so high to help bring them down. We're all for that. But the data we get has got to be accurate, actionable, and non-burdensome. So the problem we have with the idea of reporting what we get paid for 340B drugs, not what we purchase them for, we can tell you that. But what we get paid for it is we don't know. We really don't. Because some insurances pay a bundle price for the procedure. We'll pay $10,000 for, this hip replacement. Other insurances will pay, they get the bill for, this ER treatment and say, okay, we don't want to pay, $12.50. What do you say we split it 25-75? Will you take that? And they play this negotiation. How much of that, the drugs that were dispensed, were actually paid for by the insurance company? I don't know. They always take it off the total. Also, because we're a critical access hospital, we're not fee for service. So we don't itemize things. So even Medicare is not aware of how much they pay for 340B drugs. So how can they possibly provide this information that they're requesting? We can't. And we're just a small place. On top of that, the larger hospitals have software systems where they can just go in and set things up to easily find all the different numbers for all these things they're looking for. We do things manually. We have one electronic medical record system that I download all of the pharmaceuticals that were dispensed that month. And from there, it's all done on Excel screens. What is 340 eligible? What is not? If there's anything that's not, and then line by line by line by line. It usually ends up being about 2,000 medications that I have to go through to just verify eligibility of them, let alone trying to figure out who paid for them. So there would be a major burden And if it's 25-bed hospital, I think we're kind of in the middle as far as the hospitals around the state go. And I know we're not the only one. It does not have the extra software. So that's why we call it a burden. The second issue we have with reporting, as it's being requested right now, is so many of those that have testified are pointing at Minnesota this, Minnesota that. I read the Minnesota reports, and it says it said Minnesota received a 90% response rate. The very next line in that report says, however, nearly every submission had data quality issues requiring MDH to conduct extensive follow-up efforts with reporting entities. Well, that's more time, effort, and money. It goes on to say that they identified 3 data challenges, with the most important being failure by most entities to report data for office-administered drugs dispensed to a provider and administered in an outpatient setting. Well, these are just the same drugs we're talking about. For ease of, we'll just call them the infusions, because those are the hardest by far to get a breakdown from. And then the Minnesota fix for this year. Now, mind you, it's the 3rd year Minnesota's been doing this. And this is the 3rd year they've come up with yet another fix. You read their fix for this particular issue. They want to use the J codes that are assigned because all procedures are coded. To use the J codes that are service line payments. Note, this step excludes any drugs bundled through a bundled payment, including inpatient diagnosis-related groups or bundled outpatient procedures. Okay, we're back to the bundled payments again. So we're not getting the info from the bundled payments, which is the one that the insurance companies are complaining about the most. Okay, so that means we are not getting accurate, actionable, or non-burdensome payments. So to me, best bet would just be let the bill go through as it was introduced and amend it. Have somebody go through and say, all right, we know it's not working for Minnesota because they're working on it. We'll see what they learned. Most definitely. We'll see what the government's doing because the government's trying this coding method as well. The federal government. There's got to be
That's
some way.
scary.
I know, right?
Right.
That would be a to have.
There's might be some way. There is wholesalers. We know that the wholesalers know exactly what is being spent to, at least as far as what entities. And you know by, maybe not senators, pharmacists know by drug type what is infusion and what is not. So, you know, a committee to study such a thing might be a wise idea. And then this bill, if passed as it was presented, could always be amended.
Thank you. I'm confused. The bill as presented versus what we have here in front of us.
And the bill as it is doesn't have the reporting in it and doesn't have the Minnesota process. But we've heard from Pharma to go with Minnesota, and then I'm gonna point to a friend.
Seven Green from us. I think the bill as passed by the House, which does have reporting requirements, it has a start for reporting
Oh, that,
requirements
yeah.
that we can manage
Yes.
at this point, and then work towards other reporting that would be possible.
Okay, because we haven't done anything to the bill yet.
We haven't done anything to.
Okay, okay. Thank you for clarifying that.
We are going to do something for those.
Sometimes, sure. Okay.
Thank you. And very empathetic with the level of work that you have to do. It's a lot of work that you're doing for your, for Gifford. And so, what I would also say is we're working on electronic health records in here. Maybe someday you'll have the system that you need that will help smooth all that work out. Someday.
Affordable system, hopefully.
Right. Affordable. I think there it is. Affordable system. Thank you, Dawn. Appreciate it. All right. So Jeff, we only have 10 minutes left and we have your written testimony. If you could say 2 minutes worth, I would have you sit up here, but no more than that. We don't have time for a long conversation. I don't know.
I do.
For the record.
For the record, Jeff Hochberg, Development Pharmacy. I just want to, well, I submitted some comments, suggestions, about where the committee should look, ascertaining data sets, which would be. And again, point to the wholesalers, they know all, they see all. They are regulated by OPR, licensed by the state. There's potential there. That said, there's also concern, 340B program has been abused across the country. There are many examples of that. Pharma is not wrong in expressing great concern. The fact that you heard testimony that there were 800 contract pharmacies for the FQHC within this state, when there are only 14 independent pharmacies left in the state, and all the chains are looking at exit is a problem. Suggestion would be that at least you maybe protect the rights for pharma, and manufacturers have pushed back on that by creating limitations on the number of contract pharmacies a certain FQHC can have. So that has limited all the local pharmacies and their abilities to participate in the program that's relevant. So it is in dire need that this committee understand the importance of transparency of 340B, because if all of you cannot articulate how 340B drugs impact premiums or property taxes even, then we're seriously lacking our information. So we need to understand how it works. From my perspective, from everything outside of the inpatient setting, it's all virtual. I do business as normal in our pharmacy. We transmit claims. Third party is capturing my data or on behalf of the FQHC. They are saying, these are the qualifying drugs. They submit an invoice to my wholesaler or to the FQHC's wholesaler for a replacement product, which then just becomes a credit to my account. So it is all virtual. No product is even goes back and forth unless you're talking the workarounds that are potentiation for abuse, which are called alternative distribution models that Dartmouth is already, I think, doing, which it's well and good if run correctly, but there's a lot of potential that can cause for concern. So lots to be done.
So do you have suggestions for the bill in your written text?
Yes.
So that we'll use that.
Yes.
Thank you.
Absolutely.
Good. Thanks for being here today. And we'll, as we go forward, we may ask for additional information, but
Anytime.
good. So committee, I'm gonna wrap for the day. We've had a big day and there's a lot of information here and we will come back into 266 and dive into it.